Welcome to AETCM, the emergency medicine channel. Shall I start? Presenting the case of a 65-year-old male who came to ER with complaints of swelling, redness, and blackish discoloration, along with pain along the scrotal region and the penis since last 2 days, along with fever since last 2 days. On initial 10-second assessment, the patient was conscious oriented and talking in full complete sentences. And the airway an assessment, the airway was patent. There was no pooling of secretions or gurgling sounds or stridor. Breathing wise, the respiratory rate was 22 per minute. Chest was clear. Air entry was bilaterally equal with a saturation of 95% in room. And circulation wise, the heart rate was 110 beats per minute, with a BP of 100/60 millimeters of mercury and a capillary refill time of less than 2 seconds. And disability wise, the GCS was E4, V5, M6 with pupils equal and reactive to light of 2 mm. And the exposure wise, the temperature was 100 degree Fahrenheit. There was no presence of any additional rashes all over the body. We assessed the pain score also. The patient had a pain score of 7 out of 10. So we had initially given an injection paracetamol because the patient also had a fever. Spike of 100 degree Fahrenheit. So 1 gram IV stat was given for this patient, following which we reassessed the pain score after 10 minutes, which the pain score was 4 out of 10. And the repeat temperature was 99 degree Fahrenheit.
Patient was triaged into which category?
This patient was triaged into yellow.
Yellow. So yellow patients, when should you reassess the patient?
Ideally, it's after within
10 to 15 or 15 to 20 minutes you need to reassess. Okay. Yes. So you reassessed and the pain score was significantly low?
Yes.
Low compared to first pain
yes, it
score.
was 4 out of 10.
Okay. What about the local examination? Here the patient has a there is no systemic toxicity as such, no?
Yeah, as such there was no systemic toxicity.
Okay. So what about the local examination part? So we won't go much into the systems. We'll anyway focus on the local examination part. Okay.
And also we just focused on some points in the history wise. We asked whether the patient had any history of dysuria or any discharge from the urethral meatus. The patient denied giving any history of discharge from the urethral meatus or any dysuria.
Why did you ask that history?
So in cases of acute scrotal pain and swelling, we must rule out that whether patient is having an underlying urinary tract infection or like presence of any melanoprostratis or epididymoarthritis also. So that is one of the possibility which is present. So that's why we ask this history. And another thing is what we ask is the presence of any trauma to the scrotal region. So that also that acute trauma to the scrotal region can also lead to a torsion in the testis region. So that can also occur. Along with an ulceration in the scrotum also can occur.
Yeah, because there is a skin breach through which organisms can enter and cause infection. Yes. So trauma history is also important. Okay.
So this was the
Will a torsion, this patient had like the entire scrotum was enlarged and swollen and all, no? Yes. Will a torsion present like that? A torsion testis, will it present like that?
Torsion is usually
unilateral usually. So usually the torsion may not present like this. It is not that it won't present, but normally it doesn't. Okay, so you asked about the trauma history, you asked about the dysuria and any pus discharge and all, and anything else in the history that you should ask? So what do you suspect? A patient coming with an acute onset scrotal swelling with discoloration and everything. So what is that comes into your mind? What will be a differentials?
This we can take it as a necrotizing fasciitis of the scrotum.
Okay. So called as?
It's called as a Fournier's gangrene. So that's what we came into the primary suspicion.
Other differentials will be?
Other differences would be if the patient did not have any discoloration, we could come to a diagnosis of possible epididymoarthritis is another possibility. Or if it's a unilateral scrotal swelling with
what is that sign that you get in epididymoarthritis on examination?
Front sign.
Front sign. What is that on elevation?
The pain reduces.
Okay. Epididymoarthritis or so that is one differential. It can be cellulitis of the scrotum. That can be one differential. It will also present like this only with local examination showing edema, erythema, local rise in temperature, everything might be there. And other than that, there is pyoderma gangrenosum also, which can present like this. It has its own risk factors and all, inflammatory bowel disease patients. It is commonly seen in those kind of patients. So that is one differential.
So we also asked about the COMOPs. So this patient is a known case of type 2 diabetes and systemic hypertension.
So what are the risk factors that a patient can present with in Fournier's gangrene?
So the risk factors mainly includes whether the patient is in any immunocompromised states. So one possibility is the patient could be a diabetes, type 2 diabetes,
any malignancy
or any hematological malignancies,
any chemo, any chemotherapy or not. And all these things that we mentioned in the history, like any breach in the skin caused by some trauma, any urological procedures, any surgeries done and all can cause this. So these and all things can lead, they are all risk factors for Fournier's gangrene, which is necrotizing fasciitis of the scrotum. So what is necrotizing fasciitis? What happens in necrotizing fasciitis?
It's usually there will be
what are the layers of skin, layers that is involved in necrotizing fasciitis? All the layers, epidermis, dermis, subcutaneous tissue, underlying muscle involvement will also be there. Will a patient with cellulitis or any other complaint will present in a condition where patient is not able to feel anything in the scrotum in that area and all? Will a cellulitis present? Which do you think will present like that? Like a patient is complaining of the absent sensation, decreased pain in that area, but the patient is having discoloration. It is more likely a Fournier's. Why? Because all the superficial nerves, everything will get destroyed along with the destruction of the muscles and the other layers of the skin. So such patients, that normally they say that will be the initial presenting complaint. Only after that the discoloration and the edema, erythema develops. That is one thing. Okay. And about and what are the types of necrotizing fasciitis? There are two types broadly classified into type 1, type 2. Type 1 is mainly polymicrobial. You need both aerobic, anaerobic, gram-negative, gram-positive organisms. Mostly, you need anaerobic organisms like Bacteroides, Clostridium, Streptococcus. Along with that, this Enterobacteriaceae group like E. coli, Klebsiella, Proteus, everything. And other than group A, Streptococcus, other than that, some very rarely Pseudomonas can occur, and very rarely Candida fungal infections can also lead to this. And type 2 is monomicrobial, which is mainly caused by group A Streptococcus alone or any other beta hemolytic Streptococcus. They are the two types of this necrotizing fasciitis that we see. So antibiotic treatment will be according to that. So in a patient with necrotizing fasciitis, what are the local examination findings that you will see?
So initially on inspection, there will be presence of redness or presence of a blackish discoloration. So that is one of the initial findings which we get. And on palpation,
other than that, there will be ulcerations. There can be bulla formation. Everything can be there. Yes. Skin will be properly necrosed and discolored. Okay, on palpation.
Now on palpation, we will be getting a local rise of temperature with a swelling. Along with that, there will be presence
induration
of
will be there
and tenderness. So sometimes tenderness might not be present due to the destruction of the local nerves of the region.
And sometimes we can get crepitus also. Mainly if it is caused by gas forming organisms, you can get crepitus also. Okay.
And cremasteric reflexes usually will be present, but if nerve destruction occurs, the cremasteric reflex will
be absent also. Okay, so these are the local examination findings. And necrotizing fasciitis, since it is a very severe infection, it can also have systemic toxicity also, like fever. Patient can have tachycardia, hypotension. So the treatment also, irrespective of the treatment of necrotizing fasciitis, we have to also focus on hemodynamic support. Okay, so these will be local examination. And systemic patient can have other systemic toxicity signs like myalgia, full body weakness, and everything can also be present. So these are the things. So do we need a radiological investigation for this? What will be the investigation that we will do?
Ideally, we can go for an ultrasound or scrotum or local site.
Why? What are you expected to see in an ultrasound?
Ultrasound, we mainly look for the presence of the collections. So usually it is called as we look for the scrotal wall thickening. Thickening, and is also called as dirty shadowing.
Dirty shadowing. It is because of the gas forming organisms. What is the investigation of choice?
It would be a CT.
It is CT. In CT, you can see this gas in the soft tissues can be is very specific. Other than that, you can see some heterogeneity. It can be there can be fluid collections can be there. So these and all can be seen in CT. So does this we actually need to do a radiological investigation?
It is actually not necessary, because it's always such conditions are urological emergencies.
So it has to. We have to do the treatment, start the treatment much before, and need not wait for the radiological investigation to happen. Okay, so what is the treatment?
So this individual, we had initially itself started on. We look for the other signs of any systemic hemodynamic stability. So patient was hemodynamically stable. So then we had even given pain medication. So initially the medications analgesics, analgesia with antibiotic we had given for this individual. Along with that, we started him on antibiotics. So antibiotics mainly involves the coverage for both
broad spectrum.
Along with that, giving an anaerobic coverage.
So what is the antibiotic that we give?
Initially, we had started him on piperacillin and tazobactam. We had 4.5 gram IV. Those we had given. Along with that, we had given a clindamycin 600 mg IV stat
for the antitoxin.
For antitoxin and anaerobic coverage. We had given. So that was the.
If piperacillin, tazobactam, what is the alternative to that? If that can't be given,
meropenem,
carbapinum group can be given.
Group is another alternative.
And you, in case if you suspect, you can give an MRSA coverage also.
Yes,
Vancomycin can also be given. Okay, so that comes to the broad spectrum antibiotic that has to be given anyway. From there, we have to start antibiotics. Before that, we have to take the cultures also.
Yes.
Other than that, what are the next things that we have to do?
Then we should always ask for the immediate urology consult. So the ideal. This can move on to a sepsis. So the ideal treatment in a sepsis is to remove the source.
Debride, surgical debridement.
So surgical debridement is the ideal treatment in this situation. So we had called urologists, and they had done debridement for this patient also, following which the patient's general condition had improved. Yes.
So it is basically treatment is surgical debridement, antibiotic, and giving a hemodynamic support.
Yes.
Okay.